In aging populations, obesity presents a dual challenge. Not only does it significantly increase the risk of developing various cancers, but it also worsens outcomes for those already diagnosed. This double burden, heightened cancer incidence and diminished treatment success, complicates every stage of care, from prevention to survivorship. As more adults reach older age with excess body weight, the healthcare system is grappling with how to manage this convergence of risks in a way that is both effective and humane. The biological mechanisms linking obesity to cancer become even more problematic in older adults. Chronic low-grade inflammation, altered hormone levels, insulin resistance, and immune system decline all contribute to a pro-tumor environment that is exacerbated by aging. Adipose tissue itself acts like an endocrine organ, producing estrogen, leptin, and inflammatory cytokines, all of which have been implicated in promoting the growth and spread of cancers such as breast, colorectal, pancreatic, and liver cancer. In the elderly, these pathways are often compounded by other age-related changes in metabolism and immune surveillance, making cancer both more likely and more aggressive. Beyond increasing cancer risk, obesity in older patients directly affects how they respond to treatment. Surgical outcomes are often poorer due to increased complication rates, impaired wound healing, and greater anesthesia risks. Chemotherapy dosing becomes complex because body mass does not always correlate well with drug metabolism, and higher doses can lead to greater toxicity. Radiation therapy may also be less effective or more difficult to deliver in patients with larger body sizes. These treatment challenges are compounded by the fact that obese older adults are more likely to have other chronic conditions, such as cardiovascular disease, diabetes, or osteoarthritis, that limit their resilience during cancer treatment. Moreover, frailty is not always visible. An older person with obesity may appear robust but still be functionally compromised, especially in terms of cardiovascular fitness, mobility, and muscle mass. This phenomenon, sometimes referred to as sarcopenic obesity, occurs when excess fat masks serious muscle loss and physical vulnerability. In cancer patients, this combination increases the likelihood of treatment intolerance, longer hospital stays, reduced quality of life, and earlier mortality. It also makes rehabilitation and recovery more difficult, both physically and psychologically. Access to appropriate care poses another major concern. Older adults with obesity may face stigma from healthcare providers, leading to delays in diagnosis or suboptimal treatment planning. Routine screenings can be harder to perform or interpret in people with higher body weight, which can result in later-stage diagnoses. And even when cancer is detected early, some providers may be reluctant to pursue aggressive treatment in older obese patients, assuming, sometimes wrongly, that they are too frail or unlikely to benefit. These biases can silently ration care and worsen outcomes. Long-term survivorship is also more complicated in this group. Obesity and aging both increase the risk of cancer recurrence, second primary cancers, and non-cancer-related health deterioration. Survivors often face higher rates of disability, depression, and social isolation, especially when compounded by weight-related mobility issues and the lingering effects of aggressive cancer treatment. Lifestyle interventions that promote healthy aging, like physical activity, improved nutrition, and social support, remain critical, yet many older adults struggle to access these resources consistently, especially after cancer. The system is largely unprepared for this growing demographic. Most clinical trials underrepresent older adults with obesity, meaning that evidence-based guidance for treating this group is thin. Geriatric oncology, a field focused on tailoring care for older cancer patients, remains under-resourced and often disconnected from obesity care. The result is a fragmented approach that fails to address the complex needs of a growing segment of the population. Ultimately, tackling the double burden of obesity and cancer in older adults requires a more integrated and anticipatory model of care, one that recognizes the full biological, psychological, and social complexity of aging with obesity. It demands better screening tools, individualized treatment plans, and post-treatment support systems that don't leave older patients behind. Ignoring the intersection of age, weight, and cancer is no longer an option. The burden is rising, and unless healthcare systems evolve accordingly, too many will suffer needlessly in the final decades of life.